All right, take a deep breath. This is one of those denser topics. So this morning we talked about PAs and NPs and how we all kind of work together and feel good. And this is a very different topic. This is one of my favorite topics because we, in part, well, for many reasons, but we see so much of this. We see chest pain and chest pain and chest pain, and you'd think we would know exactly what to do with it because we see it all the time, but we really don't. And I think over the last really even just 5 years, this has evolved significantly. And it'd be nice to see the guidelines evolving as well. And that's really the question we're addressing here. The 2014 AHA, ACC, UA, NSTEMI guidelines, risk stratification and diagnosis. And one of the things that's interesting is if you go to the guidelines, the term UA, unstable angina, is not in the title anymore. So it follows the notion that unstable angina maybe doesn't really exist. And as we get more and more sensitive with our troponins, you either have a troponin positive patient or a troponin negative patient. It's a very interesting topic. But what we're starting with in the first couple papers here is essentially guideline bashing. So we're looking at the value of these 2014 AHA guidelines. And the first three articles really talk about how crappy guidelines are. And so let's dive into that a little bit. The first article looked at 53 guidelines from the AHA, which is always tied into the ACC, the American College of Cardiology. And it looked at them from 1984 to 2008 and said, how have they changed over time? And you would hope that they'd get better over time, that the level of evidence would get better, the things we know, we would know better, the things we know don't work, we would know that too. And unfortunately, that's not what we're seeing. These guidelines, first of all, are getting denser. So the number of recommendations have gone up by 48%. So a 50% increase in the stuff they're just telling us to do now. It's like, well, okay, I could live with that if you really knew what we knew. And unfortunately, the level of evidence behind these extra 50% recommendations is crappy. So one thing to step back, because it's a little bit confusing. First of all, we have recommendations on what you should do. There's level 1, level 2, level 3. And then there's level of evidence backing up those recommendations. So it's a little hard to keep that keep track of that. So a level 1 recommendation is, we think you really should do this. We feel it works. Everyone should be on board with this. Level 2 is, we're pretty sure it works, and then they take 2A and 2B. 2A is a little bit better, 2B not so much, but it probably works, although we recognize that there's some difference of opinions here. And level 3 is, don't do it, it's harmful. And then you take the evidence. Level A evidence is good evidence. So it's largely multiple randomized controlled trials or meta-analyses that we really feel we've got the data behind it, so that's level A evidence. You hope you've got level 1 recommendations backed up by level A evidence, but that's not certainly usually how it works. And then there's level B evidence, which is, better studies, and then there's level C evidence, which is often observational studies, or you get into the real muck here, which is standard of care. We do it because we do it, or expert consensus opinion. And when you look at the AHA guidelines, 48% of them, so there's that 48 number, almost 50% of the recommendations are level C evidence. So it's basically, we do it because we do it because the experts tell us to do it, but in terms of the quality of evidence, it's really fairly crappy. Article number 2, reassessment of clinical practice guidelines, go gently into that good night, which is basically a way of saying, it'd be nice if so many of these guidelines just went away because they're really crappy. So, I think if we went around the room and we said, well, do you know what the guideline recommendation for this is? The answer would be, no, I really don't. And I think we all feel sort of this sense of shame and guilt. It's like, oh, I should know the guideline. I don't know the guideline. And that's one of the problems with guidelines, that they're out there, we sort of know they're out there, but nobody really knows them. And why don't we really know them? Well, some of it is because, as we've talked about, the quality of the evidence is just kind of crappy anyway. So they're not so much guidelines as expert consensus opinions. And then also, as you see with the AHA, 50% more recommendations over 16 years. These guidelines are getting denser and denser, and so they're almost impossible to read. I mean, if you sit down with these AHA guidelines, it's 140 pages. So who is going to slog through that? And even if you did make that effort, are you going to remember it? So maybe the gems, the pearls are being lost in the minutia of these guidelines. There are other problems with guidelines. Specialty societies put out their own guidelines, in part to promulgate their specialty. Some of these can be drug companies sponsored to promulgate their drugs. And so much of this is duplicative. There are 10 different adult pharyngitis guidelines that you can find. So do we need all those guidelines? And of course the answer is no. How well do these guidelines hold up over time? So article number 3 looked at the durability of Class 1 AHA guidelines. And again, Class 1, these are the recommendations we know you should do. We got it down. Pay attention to this one. Well, if you follow them over time, 20% of them change. So 20% of the Class 1 recommendations were either eliminated completely or downgraded to 2A or 2B. So, and if you look at which ones those mostly were, it was not surprisingly the ones more commonly backed up with level C or level B evidence. And so now that 50% of the guidelines are backed up by level C evidence, it kind of gives you a sense of the future of our current guidelines. So in 10 years, how much of what we're being told now is going to hold up, and if the past is any hint of what's to come, it's not going to be all that much of it. The next couple abstracts, starting at number 4 and going through number 8, I think, pull out some of the decision rules for patients who present with chest pain in the ED, and how helpful are these? So abstract number 4 is called the Sanchez Rule, and I'm not going to dive into the details of all but one of these, because I think one you should know. But I think the value of some of these is you can look at what items they listed as worrisome. And I think since most of us are operating not on a checklist, what's the score when you walk out of the room of a patient, but we're still doing that Gestalt assessment, it's a very nice way of adding to your Gestalt database. So the Sanchez Rule, if you had 2 or more episodes in the previous 24 hours of whatever it is you were coming in with, so presumably chest pain, 2 or more episodes of those, if you were age 55 or older, if you were a man, if you had diabetes, family history, those got you all your points for the Sanchez Rule. And again, I don't think you have to worry about the actual scoring system, but those kinds of things, I mean, we do that for the most part anyway. If you're older, if you have more than one episode, if you have some of those risk factors like diabetes and family history, we're already hopefully incorporating that into our line of thinking. I think there are obviously problems with the Sanchez Rule. Just being over 55 is immediately putting you in a higher risk category if you're a man. So any man over 55, he could walk in saying, oh, it kind of hurts here when I twist. But if you start thinking, oh, the Sanchez Rule, that gives him 2 points, then you're starting to get off, obviously, on an incorrect track. Abstract number 5 is the Vancouver Rule. And I think you probably haven't heard of a lot of these because they've not been validated. So these are out there, and a way that most of these are derived is people in a particular institution, obviously in this case Vancouver, they take a chest pain population and then they have this checklist and they check off the 30 things that these people have, and then at the end of the day they try to shake it out and to see what 5 things land on the table. And in this case, the 5 things or so were it said, in those older than 40 years old with a normal EKG and low-risk pain characteristics, such as non-radiating pain, pain increasing with a deep breath or with palpation, and 2 sets of negative enzymes, they were okay. It's like, well, okay, that didn't help me much. They've got 2 sets of negative enzymes, they've got a normal EKG, and their chest pain really didn't sound ischemic anyway. I didn't need a rule for that. I knew that one. So that's why some of these aren't terribly helpful. Abstract number 7 is called the Hess Rule. And again, it's non-validated. They found that in the absence of ischemic EKG changes, history of CAD, pain typical for acute coronary syndrome, and as long as you had a 6-hour troponin level that was negative, and they were less than 50, they did okay. It's like, oh, okay, thanks very much, Hess rule. That didn't help again. Now, backing up, though, to abstract number 6, this is the heart score. And this is getting a fair amount of press lately. And those of you who are EM Wrap subscribers, if you get the emails that when they have their like little breaking news, this was one that Amal Mattu put out a little talk about recently. And I think it's worth knowing for a number of reasons. One is that it's been validated. So again, it was an initial group of investigators who came up with this idea, and they said, you know, it worked in our population. And then it has subsequently been validated in this abstract number 6. 2 is it's stuff that we do automatically on a prospective basis. So this is the patient who comes in, and everyone you take a history on, you get an EKG on, and you're asking about their risk factors. And then if you're starting to go down the ACS pathway, you're getting a troponin. So the heart score is really just all that. The H is the history, the E is the EKG, A is for age. So if you're younger than 45 or greater than 65, that's the cutoff. Younger than 45 gets you 0 points. Greater than 65 gets you 2 points, and anywhere in the middle you get 1 point. Risk factors and troponin. And it's also sort of a scoring system, although I think you'll probably want to pull up MD Calc or something like that to help you along. You can kind of remember the scoring system because history is broken down into, did this really sound like ACS? Was it highly suspicious? That's 2 points. Was it moderately suspicious? That's 1 point. And then if it was just slightly suspicious, that's 0. EKG, significant ST deviation, 2 points. Non-specific changes, 1 point. Normal EKG, 0 points. We talked about the age thing. Risk factors, 3 or more risk factors, 2 points. 1 or 2 risk factors, 1 point. No risk factors, 0. And then what's interesting in this study, this was, I think, a Dutch validation study, troponin. Troponin is now so sensitive, and we'll talk about this more in a minute, that a positive troponin was only one of those considerations. So they were still sending people home with positive troponins if nothing else really added up. But I think most people in the US would be a little bit uncomfortable saying, well, it really didn't sound much like ACS, and EKG was fine. And even though the troponin was 3 times the normal limit, that was still only a score of 2, so I let them go home. So I think what most people are doing in the US who are using the heart score is they're using a heart modified score with troponin being kind of a dead end point. If you have the elevated troponin, then further workup is forthcoming. But everything else, the history, EKG, age, and risk factors is being incorporated. In this study, abstract number 6, when they looked at those who had a heart score of 0 to 3, the risk of significant cardiac adverse event, and that's always, it's that MACE thing, M-A-C-E, major adverse cardiac event, and that's always death, MI, revascularization, and it's almost always revascularization. But if your score was 0 to 3, first of all, 36% of the population hit that. So at least a third of the people that they applied this to are considered very low risk and not worthy of any further study. So their outcome of a major adverse cardiac risk was only 1.7%. And the one death in that group was a 20-year-old who committed suicide a week after being seen for chest pain. So it's considered by many that an under 2% risk of MACE in a follow-up period, and it was a 6-week follow-up period, that's about as good as you're going to get. If you start trying to eliminate that to zero, you're going to do more harm than good. That's the whole concept of a test threshold. At some point, you got to say, this is good enough. In the patients who were in the intermediate range, points of 4 to 6, they had a intermediate risk of complications, so their MACE risk was 17%. So about 1 in 6 patients who scored 4, 5, or 6 had a major adverse cardiac risk event. And we'll talk about that in a moment. And then if you scored a 7 or higher, your risk was 50%. So that's a really high-risk population. So the value of this heart score appears to be, and I suspect more people will be validating it, will be that the people 0 to 3, the very low risk, they're really low risk. And it's a fair percentage of the population. If you look at the Hess score, their low-risk population, only 1 in 5, 20% came into that group. So you were still keeping 80% of your patients anyway. If you went with the heart score, at least you're getting rid of a third of your patients right off the bat. And it also appears to be a good predictor of the high-risk patient. So I think you could say, hey, this guy's got a score of 8. I'm done with him in the ED. This is a 50% chance of a major adverse cardiac event in the next 6 weeks. Medicine and cardiology can deal with them. So it's that intermediate group, as it always is, that I think we're left trying to deal with. Many people who have talked about the heart score still say, well, intermediate risk, 1 in 6 major adverse cardiac event in 6 weeks. You're going to want to work up further. And maybe you do. I think that would still potentially be an avenue for that shared decision-making with patients. You got a 1 in 6 chance of something bad happening in 6 weeks. Most of them would probably still go on for further workup. Question talks about what do we do with EKGs? Very quick answer, and I think it makes sense that if you have a high suspicion for ACS and the patient remains symptomatic, you get another EKG. So this suggests you do another one in 15 to 30 minutes. Sure, let's go with that. The next question talks about troponins. When are serial measurements useful and at what intervals? How many people in here are using the new high sensitivity troponins? We are. We just switched in December. We used to have troponins we believed, and now we have the high sensitivity troponins. The original troponins that came out, Generation 1, had a threshold of positivity of 500 nanograms per mil, 500. The current troponins are between 1,000 and 10,000 times more sensitive than that. So as you ratchet down the threshold, obviously 2 things happen. Your sensitivity goes up and your specificity goes down. So troponin is becoming, unfortunately, the new D-dimer, that you can believe the negative troponins and you can't so much believe the positive troponins. And if you start looking, that's abstract number 8. It's a really interesting read about the current high sensitivity troponins. We can now detect troponin in normal people. So it used to be if you found troponin, it really was a real finding. And now we have to have a threshold whereby 99% or lower is considered normal, but we're still able to detect it in that 99%. What's interesting was we're also finding variability, and not so much just from one person to the next person, so it's hard to figure out what the normal range is. We have that. But we also have variability from one person to himself within a few hours. So the troponins can vary from 46% in one direction to a third higher. So you get a range of almost 75% change if you take the same person and you measure his troponin serially. Very disturbing. There's also, of course, the lab variability. So how reliable is the lab test? You take the same sample of blood and you run it twice, you can get up to 20% variability. So all these reasons that the solid ground of troponin that we used to stand upon is now a whole lot shakier. There were two papers, they're not in the database, but abstract number 8 talks about them, from 2009 in the New England Journal of Medicine that looked at these new high sensitivity troponins, and serial sampling did not significantly increase diagnostic performance. So one of the questions in here is, when do we get our troponins? How often do we repeat the troponins? And I think it's coming down to the following. So if the patient comes in under 2 hours, your troponin at that time, even the high sensitivity ones, are not reliable. So it's about an 80% sensitivity from 0 to 2 hours. From 2 to 4 hours, it's going up almost to complete reliability. So one of these articles quotes 95% sensitive from 2 to 4 hours. And then you get a little bit extra if you go all the way out from 4 to 6 hours. So you can get up to that 100% all the way out to 6 hours, but you're doing real good up to 4 hours, not so hot 0 to 2. And that's abstract number 9. Question, according to the AHA guidelines, must all chest pain patients undergo provocative stress or imaging testing? It seems like they've softened their language a little bit about this, but they remain vague. So the quote from the guidelines, it is reasonable for patients with possible ACS who have normal serial ECGs and cardiac troponins to undergo further testing before discharge or within 72 hours after discharge. So it is reasonable. So it's not saying you must. It's not saying it's reasonable not to, though. So it seems like the guidelines are still very much on board with non-invasive stress testing or CT scanning. They consider those sort of equal footing. But it's certainly not a mandatory, which is nice to see, although it'd be nice to see a little bit more. Abstracts number 10, 11, 12, actually I think through the rest of the talk, try to debunk the value of a lot of this stress testing. So abstract number 10 talks about this 4,000 patient population, pretty much everybody's getting stress tests, and how much good did we do? 0.7% got revascularization. So you took 4,000 patients, and less than 1 in 100 did we actually do anything to. That doesn't sound like a great yield to me. Abstract number 11, the Schurmeyer paper out of British Columbia. I really like this one because it's largely what I'm doing, what my department is doing. They took over 1,100 patients, consecutive chest pain patients, and you had all these different routes. So if you were really worried about the patient, and that was like 20% of the population, they just got admitted to medicine. So they peeled off and they went off to medicine. And then you could keep people for different lengths of time. So if you really weren't worried about them and maybe they came in a few hours into their chest pain, you got one troponin and they were gone. If you wanted to watch them more, some of them stayed up to 6 hours. But 60% of them were discharged without any additional testing. So a full 60%, no stress test, no CAT scan. We watched you, we did an EKG or two, we did a troponin or two, and we weren't that worried, and off you went, and 60% of that population met those criteria, and they had no deaths, no missed MIs at 30 days. So it seems like a reasonable, functional outcome that some people get admitted right away. The other subsegment got referred for outpatient stress testing. So some admitted, a few outpatient stress testing. But the majority, 60%, we just do our ED testing and we wave goodbye. And that's largely what we're doing, as I said, in my emergency department. Abstract number 12 talks about, again, the value of our stress testing craziness. It points out that we didn't used to do so much. We do way more. We revascularize more, but the outcomes haven't improved. And if you look at a lot of these studies looking at early invasive strategy versus medical management wins or does just as well every time. So the value of we got to figure out if you got coronary artery disease is really very diminished when you can just do medical management. Abstract 12, I think we just talked about. But one thing I did want to point out, abstract, let me see, chest pain. All right. I did want to bring up the whole CT coronary angiogram approach, which is very popular in some places. How many people here are sending a lot of their low-risk chest pain patients to CT coronary angiogram? Anybody? I'm actually I'm kind of happy to see not a lot of arms going up. Because there has been no study that finds improved outcomes by heading down the CT coronary artery route. The only improved outcomes that these studies can hope to find is that you can do it quicker. So if your current protocol is, well, we keep everybody overnight and we do a stress test in the morning, obviously that takes some time. And if your protocol can now be, well, we'll send them to CT and if it's negative, we'll send them home, then that's quicker. And so they're publishing these articles that saying, look how good we're doing. We got them out of the ED in 7.2 hours quicker than the old route. And I would like to refer people, if there's something you want to read, it's a Rita Redberg, who's a cardiologist out of UCSF. She commented on some of these CT coronary artery angiogram articles in an editorial in the New England Journal of Medicine, July of 2012, and I'm just going to read verbatim from parts of her editorial that discussed these approaches using the CCTA. She talks about, both studies confirm the somewhat unremarkable fact that CCTA provides faster diagnostic results than standard evaluation, which meant some type of stress test in 74% of the patients studied. Well, I'll skip that part. So she said, yes, you can do it quicker. The studies by Hoffman and Litt, those were two of the bigger studies published in the New England Journal looking at CCTA, showed that assuming a radiology department can read the CT scan promptly, it is faster to obtain a cardiac CT scan than a stress test. Of course, it is even faster to discharge these patients without any additional diagnostic tests after determining that their ECG findings and troponin levels are normal. The underlying assumption is that some diagnostic tests must be performed before discharging low to intermediate risk patients from the emergency department. This assumption is unproven and probably unwarranted. Patients who have normal electrocardiographic ECG findings and negative troponin levels constitute a group at low risk for cardiac events, and multiple studies show no evidence that any additional testing further reduces that risk. The decision regarding the need for diagnostic testing in these patients usually can be safely deferred to outpatient follow-up within a few weeks after the visit to the emergency department. The vast majority of patients have no cardiac causes for their chest pain, and many need no further testing. Thus, with no evidence of benefit and definite risks, routine testing in the emergency department of patients with low to intermediate risk of acute coronary syndromes should be avoided. So you've got the AHA on one hand, you've got a little bit of backup in the New England Journal of Medicine editorial. It'd be nice to see the AHA catch up, but I think that's at least a little bit of evidence that we can take a little breath and not be so crazy with a lot of these low-risk chest pain patients. All right, thanks.